overview of the lecture. We'll discuss brain in terms of structure, including protective structures, divisions, neural networks. We'll go over the brain studies. We'll dip a little bit into brain disorders, and we'll describe the cranial nerves. Please take a moment and stop the presentation if you want to review the learning objectives. We'll look first, we'll go very didactic, and we'll look first into the protective structures of the brain and the spinal cord. When we are going from superficial to deep layers, the first layer that will be encountered when we are looking at the skull will be the skin. Immediately under the skin, we have the skull itself, the skull bones. And if you remember from the structure of the bone, every bone is covered by a thick membrane that is called periosteum. It is especially thick in the case of the skull bones, and there is a tight attachment between the skin and the periosteum with a quite rich vascular supply at that level. Now, if we have an injury, and if you look at this picture, at this image here, you can see how there is no subcutaneous tissue. There is no fat in between the skin and the bone. That's why all the lesions of the scalp will produce usually a lot of hemorrhage, even if they are not involving the inside cranial cavity. It will not going to progress through the bone inside. There will be a lot of bleeding and big hematomas that can develop under the skin just because there is produced a dissection, separation between the layers of the skin and the periosteum of the skull bones. Moving in under the bone, the skull bones, we'll find what is called the meninges. And the meninges are the covers of the central nervous system. They cover, if you remember, we described them very quick and not in a lot of detail when we discussed the spinal cord, because we will discuss them in depth at the level of the brain. They are continuation at the level of the spinal cord. They are a continuation of the meninges from the brain. There are 3 layers, and they are made out of connective tissue. And they will, again, surround both the brain, and they will continue at the level of the spinal cord. And they cover, forming a complete enclosure of those organs. Going from the outside inside, we have the dura mater. It means the tough mother in Latin, and it's a thick and very tough type of connective tissue. Around the brain, the dura mater is made out actually in 2 layers. The outer layer, the one close to the skull bones, it's fusing itself with the skull bones, kind of making the periosteum on the other side, on the inside part of the skull bones. The other layer will, if you can look into, again, if we go into the, and we can see the picture again, you can see how in some places those 2 layers are separating themselves and will allow for some spaces where the venous channels will form. Some brain capillaries will develop over there. They are called the dural sinuses. And some extensions of the next membrane, the one under the dura mater, will penetrate, will project into those dural spaces also. At the level of the spinal cord, dura becomes just 1 layer. We're not going to have this 2 layer type of aspect. The middle layer of the meninges is called the arachnoid layer. This one is considered the vascular layer out of those 3 layers, and it's a little bit more loose and attaches with a web-like type of fibers to the next membrane, the one under it, to the pia. And it's forming a space that is called the subarachnoid space, where CSF circulates. And the name of arachnoid is given to it because arachnoid means webs or spiders. And those extensions that they are the arachnoid villi, they look like a web created by a spider. Inside the subarachnoid space, we have a fluid that is called the cerebrospinal fluid. And we also have a very rich web of blood vessels. The most inner layer of the meninges is pia mater, or the soft or tender matter. And at this level, this one is a thin membrane that attaches very tight to the nervous system, to the nervous tissue, both of the brain and of the spinal cord. And by attaching so tight to it, it will follow all the contours of those structures. It will follow all the grooves that the brain has. At this level, all the nutrients and oxygen are exchanged. And immediately after those, I mentioned before the fluid that circulates inside the subarachnoid space, and that is called the cerebrospinal fluid. It's a clear liquid, and this liquid circulates and surrounds the brain and the spinal cord. Main functions of the cerebrospinal fluid, or the CSF, is to support the nervous system and to cushion it from shocks that may be encountered during our everyday life, and also to carry nutrients to the cells, both the nervous cells and the support cells that are the glial cells, along with transporting waste products out from the cells. The CSF will be formed in four spaces that are contained in our brain, that they are called ventricles. The ventricles are layered by a structure that is called the choroid plexus, made out of blood vessels and a network of those specialized neuroglial cells that are called the ependymal cells. And this choroid plexus is responsible for producing continuously the CSF within all those four ventricles. Let's look a little bit to the image, and you can see in the lateral view how we have two ventricles that are situated anterior posterior, kind of horizontal, and they are called the first and the second ventricle. And we have also, if you look in the anterior view, you can see it way better, both anterior and first and second ventricles, right and left. And you can see the third ventricle being situated in between them, with the fourth one being situated at the base of the skull, or inside the brain. Let's describe now how the CSF is produced, and you can follow what I'm saying in the on the image that is on your slide. As I said before, the CSF will be formed by the choroid plexus, mainly in the lateral ventricles, in number 1 and 2. From there, you can see that the fluid will flow into the third ventricle. And this cavity is positioned midline within a structure that is called Diencephalon. From this third ventricle, the CSF will pass through a very small canal in another structure that is called the midbrain. And that passage is marked with number 2 in this image that you can see on your slide. And that small, very tight passage is called the cerebral aqueduct. And that will move everything into the fourth ventricle. Fourth ventricle is actually located between the brainstem and the cerebellum. A very small volume of CSF will pass from the fourth ventricle into what is called the central canal of the spinal cord. If you see, you can observe it over here, is this tiny line. So only a little bit of the CSF will run inside the spinal cord. The rest of them will flow around the spinal cord And if you follow the arrows, you see what I mean. The rest will cover the spinal cord and will get down from the dorsal side of the spinal cord up to the end of the subarachnoid space at the end of the spinal cord and will be pushed upwards on the ventral side of the spinal cord back towards the brain. You will see that while doing that is carrying the nutrients and oxygen to the nervous system, while on the other hand, taking out from those cells all the waste products. Some of the CSF will filter out of the arachnoid villi into the blood at the level of the dural sinuses. And if you do follow the arrows back, you can see how at this level they will be filtered inside the venous system. And it makes sense to be like that because the venous system is actually that place that will drain all the waste products. So while it's produced, or is number one on your picture, all the time through the choroid plexus will secrete new CSF, new fluid. It will be also continuously absorbed back in the venous system and kind of recirculated. The brain can be divided into 4 different regions that will have very specific functions. However, they are in constant communication with each other and they actually work together in order to regulate different body functions. And those regions are the cerebrum, the diencephalon, the brainstem, and the cerebellum. We'll describe them in a second. So the cerebrum represents the most superior and also the largest part of the brain and can be divided into left and right hemispheres. All of which are shaped like a boxer's glove. They are made out of, so they have 2 layers. They have an outer layer that is called the cortex, and that represents the place where all the conscious functions will take place, like thought and memory and reasoning and abstract mental functions. We know exactly where and they are located, each of those functions on the cerebrum. The second one is called the diencephalon, and will sit in the center of the brain, and it's located between the 2 hemispheres, a little bit superior to the brainstem, and it's made out of 2 parts. It's made out of the thalamus and the hypothalamus. And the main function for the thalamus is to sort and redirect sensory input. It's kind of a relay function. The hypothalamus also is the main center for the body homeostasis and will control all the autonomic nervous system functions. And part of the hypothalamus is a small gland also that is called the pituitary gland. The third part, the brainstem, represents the region between the diencephalon and the spinal cord, and can be divided in 3 parts. Can be divided into the midbrain, the pons, and the medulla oblongata. The midbrain, that part of the brain is situated below the center of the cerebrum, and as a main function for the midbrain represents the reflex center for vision and hearing. And also another function is to act as a relay and connect the cerebrum with lower portion of the brain. The pons sits anterior to the cerebellum and connects the cerebellum with other portions of the brain. Main function of the pons is to regulate respiration and the heart function. Medulla oblongata is that area of the brain that is situated between the pons and the spinal cord and is the link between the brain and the spinal cord. Has inside the centers for vital functions, along with the pons will have centers for respiration and heartbeat. The fourth part of the brain is called the cerebellum, or the little brain, and is situated posterior to the cerebrum, kind of in the back of our head, in the occipital area, and also can be divided into two hemispheres, very similar to the cerebrum. That's why it's called the small brain, because it has an almost similar structure. The main function of the cerebellum is to coordinate voluntary muscles, has a big function in maintaining balance and muscle tone. Question 1 asks, which division of the brain is physically connected to the spinal cord? And the options are the brainstem, the cerebellum, cerebrum, and the encephalon. The answer is the division of the brain that physically is connected to the spinal cord is the brainstem. We'll look a little bit in more detail to each of those structures that I mentioned before. And we'll start obviously with the cerebrum. If you remember, we said that the cerebrum is made out of, is the largest part of our brain, and it's divided into left and right hemispheres. In addition to that, each of those hemispheres is divided into four obvious and visible lobes, and the lobes are named by the overlying cranial bones. So we have the frontal lobe that corresponds to the frontal bone, the parietal lobe that corresponds to the parietal bones, the temporal and occipital that respectively correspond to the temporal and occipital lobes. We do have an additional small fifth lobe that is located deep within each hemisphere, and it cannot be seen if we do not open those two hemispheres like a book. We need to open them to see, and that tiny lobe is called insula. So we have each hemisphere covered by a layer of gray matter. That's what we see on the outside. If when we were looking at the spinal cord, the white matter was on the outside, was the outer layer, and the gray matter was making that butterfly-like type of structure inside the spinal cord. When we are looking at the brain, the white matter is the layer that is found inside the structure of the brain, while the gray matter makes for 2 to 4 millimeters thin layer of coverage. All the specific functions of the different lobes, we have different functions for each lobe that we know where they are situated. We had a good understanding and mapping of our brain in terms of functions. Before describing that, we'll go in and describe a little bit more the macroscopic structure of the brain. So again, when we are looking at the cortex, you will see that the human cortex and most of the mammals is arranged into folds, and those are called gyri, or for the singular gyrus. Those raised areas will be separated by some shallow grooves that are called sulci, or for one is a sulcus. We have a lot of sulci, however, there are two of them that are more important and more prominent. They stand out and they are considered landmarks. We have one that is called central sulcus that separates between the frontal and the parietal lobe of each hemisphere, and the lateral sulcus that curves along the side of each hemisphere and separates the temporal lobe from the frontal and the parietal lobes. Now, inside the cerebral hemisphere, if we open them as a book, we can see the white matter, and that color is given by the fact that the fibers at this place, at this point, they are myelinized, and we have a structure that we can see inside when we open those hemispheres, and that structure is called the corpus callosum. And the main function of the corpus callosum is to connect and bridge between the two cerebral hemispheres and coordinate the function between those two places. Let's start and map now the functions of the cerebral cortex. And if you look, take a look at the image, you see how big the frontal lobe is in humans. Is the biggest area and the most developed among all mammals. And as a general rule, will contain any kind of centers that will be involved in control of movement or motor abilities. So if you look at the image, you see that there is a dark red area marked very close to the central sulcus, the one that separates between the frontal and the parietal lobe. And this primary motor area is involved into conscious control of skeletal muscle, with specific segments of this area will control the muscles of different body regions and will have larger portions of the cortex involving in controlling the muscles that require more precise control, such as those of the hand or the facial muscles, as opposed to those of the trunk that need less control from us. Anterior to this dark red, you see a lighter type of red or pink, and this area is called the premotor cortex. And the main function of this place is to plan those complex movements and coordinate from different areas in planning the movement and coordinating the action of different muscles from different regions. This part of the brain will receive information from other parts of the brain that assist in this task. And anterior to this premotor area, we have another area that is called the prefrontal cortex. And interesting enough, this is involved in memory and problem solving and any type of conscious thoughts. Within the same area of prefrontal cortex, we have a small place that, if you see, it's a different shade of red over there, that is called the motor speech or the Broca area. This is the center that will plan the sequence of muscles that will trigger contractions of the tongue, the larynx, and the soft palate. And all those centers will coordinate the movement of different types of muscles in order to form meaningful sentences. Whenever a patient will have a stroke, that the blood supply to the Broca area will be involved, and lack of blood supply to that area will damage this center. One of the clinical aspects that you will see in those patients is the fact that they can articulate, they can make sounds. However, their sentences will have will be very hard to understand. They will not going to be able to express their ideas in coherent words. We are moving now into your purple area on your image, and that's the parietal lobe. So if you remember, the parietal lobe occupies the superior part of each hemisphere and corresponds to the parietal bone and lies posterior to the central sulcus. And the gyrus just posterior to the central sulcus, kind of mirroring the primary motor area, is called the primary somatosensory area. And all the impulses from the skin, regardless what type of impulses those will be, it can be for touch or pain or temperature, all this information is received in this area. Very similar to the motor cortex, there is a greater intensity and a larger area allocated for those parts of our body that have a greater intensity of sensation, as tongues or fingers. And immediate posterior to that area, similar and kind of mirroring the frontal lobe, you will have what is called the somatosensory association area, which will integrate all those sensorial information, and will integrate it with memory. And this is performed over there in order to identify physical sensation. As an example, when you are reaching for an object on your nightstand that you think that you left. Let's say you're reaching out to your nightstand to find out your phone to check the hour, and instead of that you encounter your pet. Your feelings, by feeling, you know that your hand is not touching the right object. So this primary somatosensory area will send information regarding shapes, warmth, softness, all kind of information that the touch can offer. Whenever a patient will have damage to this area, it will be impossible, very hard or impossible for them to identify objects by touch alone. And the way that we are diagnosing them is asking the patients to close their eyes. We put an object in their hand, and just by feeling it, we ask the patient to identify the structure. Usually they are not able to do that. In addition, we have posterior to this area, we have what is called the posterior association area. It's a light green on your picture. And on this area, we'll accept and integrate information from all this sensory association area and some memories in order to construct what is called an integrated view of the world. We are moving now into your blue side, a blue part of the image that is representing the temporal lobe, which is situated, if you remember, lateral, inferior to the lateral sulcus, corresponding to the temporal bone. The main functions for the temporal bone will be related to auditory, speech comprehension, and olfactory functions. The auditory receiving area will be that one, it's in a dark blue on your picture, will be able to detect sounds from the environment. And very close to that, similar to the previous two lobes that we described before, we have the association area, the auditory association area that will interpret the sounds. Not only that, you will receive the sounds, but you will be able to know what is the meaning of that sound and recognize it. Another important part of it, it's situated posterior, close to the occipital lobe, and it's called the speech comprehension area or Wernicke area. In this area, we are able to recognize speech and the meaning of words. Whenever that area is damaged in a stroke patient, they will have a hard time in understanding the meaning of speech. They will hear sounds. They hear that someone is talking with them. However, they cannot understand the meaning. For them, it's just sounds kind of like Charlie Brown type of speaking. The olfactory area will receive information regarding the sense of smell, and we can find it in the medial part of the temporal bone. It's not visible from the surface because the olfactory nerve is coming from the nose towards the central of the brain, so it's visible just only if we are opening as a book those two hemispheres and look from the inside. Occipital lobe is posterior both to the parietal and the temporal lobe, and it covers the cerebellum. It's presented in green on your in your image. And the main function for the occipital lobe is to receive visual information. We'll have a main visual receiving area, which will collect the information received from the retina, mainly in terms of brightness and color, while the surrounding area of the occipital lobe, that is called the visual association area, will interpret all this, will put together all this information and will form what is called a mental picture. So the process of memory and learning, the memory represents a mental capability of recalling ideas. And any type of memory formation process will start with an initial stage of receiving sensory signals that can be visual, auditory, or tactile. And those will be retained for a very short time and will be lost if not processed in a certain way. We have what is called the short-term memory, and that refers to retaining bits of information for somewhere in between a few seconds to a few minutes. And this type of information will be lost if not reinforced. And the long-term memory will refer to the storage of information that we are able to recall at a later time, and it's a permanent type of a storage of information. There is a tendency of memory to become more and more permanent the more a person will repeat a certain experience. Let's say the more you are reviewing a lesson, the better your recalling of the elements in that lesson will be. We know that not only as an empirical way, because just by repeating some stuff we become better in doing some tasks, but also because there were some psychological studies that show that rehearsal, repetition of information again and again, will both accelerate and potentiate the degree of short-term memory to transfer into long-term memory. Which lobes are separated by the central sulcus? The options are frontal and parietal, parietal and occipital, temporal and occipital, and temporal and frontal. The lobes that are separated by the central sulcus are frontal and parietal. We are moving now to discuss the diencephalon, the next portion of the brain. Diencephalon is also called the interbrain and is located between the previous described part of the brain, the cerebral hemispheres, and the brainstem. It is made up of two parts, made up of the thalamus and the hypothalamus. The two parts of the thalamus will form the lateral walls of the third ventricle. And the main function is the thalamus is to be a relay for all the sensory information that will travel through the masses of gray matter towards the cerebrum. The thalamus will sort out the impulses and it will direct them to particular areas where they need to produce a reaction. The hypothalamus is located in the midline and inferior to the thalamus and forms the floor of the floor of the third ventricle. It acts as the control center for any type of negative feedback that controls some kind of basic types of body processes as body temperature, needs for food intake, water balance. It also controls other body functions necessary for well-being as the sleep and awake cycles, emotions as fear or pleasures. Hypothalamus also controls the sympathetic and parasympathetic divisions of the autonomous nervous system. Now, part of the hypothalamus, if you remember, I was telling you that there is a tiny part that it's a gland. It's called the pituitary gland. We are not going to discuss this now because this is an important part. That's a very important gland, and we'll discuss that when we'll do the endocrine system. The brainstem is the next part and is composed of three parts, midbrain, pons, and medulla. Those structures connect the cerebrum and the diencephalon with the spinal cord. At the level of the midbrain, we have closed some of the reflexes that will be related to eye and ear. Those are involuntary reflexes. For example, moving of the eyes in order to track an image or to read. The pons connects the cerebellum to the rest of the central nervous system, and it's located actually in front of the cerebellum. And it has mainly myelinized nerve fibers, and it's the name actually it's related to its function. It's called the pons, and pons in Latin means the bridge. There are some certain reflexes, also involuntary, um, related to regulation of respiration that will have its centers in the pons. Medulla is the last part of the brainstem and makes the connection between the pons and the spinal cord. It contains a lot of myelinized fiber, and inside, so that's why its aspect from the outside, it looks very whitish. However, inside we have some inclusions of gray matter that are called nuclei or centers. And those nuclei are the control centers for very basic homeostatic functions of the body. Um, you can find among them the respiratory centers that will control the muscle of respiration, that will maintain a consistent blood gas level. Those centers will respond to an increase in the CO2 in the blood and will increase the respiration activity based on that to lower the value of CO2 in the blood. We have a cardiac center that regulates the rate and the force of the heartbeat. And this responds to changes in blood pressure. Whenever the blood pressure changes and drops, this center will be stimulated, and as a result of that will be an increase in the rate and the strength of the heartbeat. We have another center that is called the vasomotor center that regulates contractions of the smooth muscles inside the blood vessels. And by doing that, this center is controlling the blood flow, and as a result of that, the blood pressure also responds to drops in the blood pressure. And as a result of a blood pressure drop, this center will send a stimuli to the smooth muscles in the blood vessel, and the vasoconstriction will be the result of it. Question number 3. Which structure controls the autonomic nervous system and the pituitary gland? And the options are basal ganglia, cerebellum, hypothalamus, and thalamus. The structure that controls the autonomic nervous system and the pituitary gland is the hypothalamus. Question number 4. Which part of the brainstem contains relay centers for eye and ear reflexes? And the options are pons, thalamus, medulla oblongata, and the midbrain. The part of the brainstem that contains the relay centers for eye and ear reflexes is the midbrain. Cerebellum represents, it's named like that because it's called also the small brain. It's very similar in structure with the cerebrum and is located on the posterior and lower part of the skull. And it's made up of 3 parts, in fact. It has 2 lateral hemispheres, left and right, and they are connected through a middle portion that is called the vermis, and you can see it in this image. Just like the cerebral hemispheres, will have the outer area on the outer side will have the gray matter, and in the inside will have white matter, which is made out of axons, nervous fibers that are high in myelin. The main functions of the cerebellum are to coordinate voluntary muscles, while by doing that ensures that kind of smooth and orderly function. So when we are moving, we don't look like robots. Whenever there is a disease of the cerebellum, the muscles will produce movement that have a certain degree of jerkiness, or there will be a certain degree of tremor at the level of the limbs. Also helps in maintaining balance in all the aspects where balance needs to be maintained: standing, walking, sitting, and even during strenuous activities. The last function of the cerebellum is to maintain muscle tone. If you remember, the tone is that degree of a small contraction that is present at any given moment in our muscles. Our muscles are not completely flaccid or relaxed. And whenever the cerebellum is affected, the tonus is not maintained at the level that it should be. It can be increased or decreased. Question number 5. Which of the following is not a function of the cerebellum? And the options are maintaining muscle tone, maintaining balance, coordinating voluntary muscles, initiating movements of voluntary muscles. The option that is not a function of the cerebellum is initiating movements of voluntary muscles. In addition to the structures that I presented until now, our brain contains also a few networks that are called the widespread neuronal networks, and their main job is to connect and coordinate very select regions of the diencephalon, the brainstem. They extend through the whole brain, and they have they're involved in very clear aspects of our life. They control behavior. They may participate in motor control or may govern awareness. And we have three of those structures in our brain. The first one is the limbic system. And the limbic system has a diffuse collection of neurons that are related and involved in process that will develop emotional states and behaviors. And this system is connected with all brain regions, and it is and should be seen as that interface between the thinking part of brain and the autonomic part of brain that gains information and controls motor output. In this structure, in the limbic system, we can describe a few subsections. And the first one will be the cingulate gyrus, and that's a portion of the cerebral cortex that presents itself as a loop over the corpus callosum. And this one we know for sure that is associated with emotions and memories. The hippocampus, it looks like a seahorse. If you can see it in this picture, just look for hippocampus and see if it looks to you as a seahorse. I think that it is. And is located under the lateral ventricles. The main function of the hippocampus, and when I said that it looks like a horse, that's why the name is hypo. The main function of the hippocampus is to store new memories. Whenever we are learning new things, the process of storing information starts in the hippocampus. Whenever there are any types of lesion at the level of this structure, that person has an impaired ability to form new memories. However, all the old memories are intact. And if you remember that movie from about, I don't know, 10 or 15 years ago, 50 First Dates, that main character had a lesion of the hippocampus. The amygdala, those are two clusters of nuclei that they are located deep inside the temporal lobes. And the amygdala will coordinate emotional responses to certain stimuli. Let's say whenever you have you feel a certain smell and that reminds you of your grandma's kitchen. All those emotions that are associated to smell will be located in this center. Beside the limbic system, we have another one, and that's made out of the basal nuclei. Another name for the basal nuclei is the basal ganglia, and their main task is to modulate motor inputs and to facilitate all those motor tasks that we already have as a routine. If we need to describe the basal nuclei in terms of their structure, they are spreaded masses of gray matter. They are throughout the brain. However, they have a lot of connections among each other. And whenever they are affected, conditions as Huntington disease or Parkinson disease develop. The reticular formation is a sausage-shaped network of neuronal body cells that spread itself on the length of the entire nervous system. The reticular activating system, or RAS, exists inside this formation and will send impulses to the cerebral cortex in order to keep us awake and attentive. Also, the RAS works together with the cortex in order to identify any unnecessary sensory input, like, let's say, the traffic noise, and will try to increase the impact of new stimuli inside that kind of background noise. As, let's say, inside the whole traffic noise, if you hear a car horn sound, that will stand out against the background noise. Brain studies. That's a whole, it's a complex range of studies that we have in order to examine the activity of the brain. And if you will click on the red link, you can have an overview. Most of the times what we perform those type of imagistics techniques to study the brain. The computer tomography or the CT scan will provide 2D images, and with the new modern machines, based on those 2D images, they can create 3D imaging of the brain, and we can have information regarding the bone, the soft tissue, and any cavities in the brain. You can see the image A is showing you a CT scan of the brain, and you can see the white areas are the bones, with the gray area, different parts of the brain. Wherever you see the very dark black color in those areas, those are, this is air inside sinuses. A second type of investigation that we can do to examine the brain is what is called a magnetic resonance imaging. And as opposed to the CT scan, which is an advanced X-ray examination, the magnetic resonance imaging will use magnetic fields to produce an image. Therefore, is not producing any kind of side effects on the human tissue. MRI will give a little bit more detailed view of the brain tissue than the CT scan is doing, and that's because the MRI is able to present in detail those tissues that have a high concentration in water. So MRI is very good for tissues like brain that has an increased amount of water. The PET, or the positron emission tomography, is a way to putting together the imagistics while trying to visualize also the brain in action. And you see that you have different colors at the level of the brain. What we do while doing a PET scan, we are using a CT scan while injecting certain substances into the patient vein and registering the images of the brain while the patient is exposed to different stimuli, to noise, to sounds, and we register the activity of different areas of the brain. Those that have high activity will be red or bright red, goes into yellow, and green moves into blues and purples. The more darker the color, more purple, it means that that area of the brain is totally inactive. The more red the area is, it means that it's active. We do use the PET scans, especially in Alzheimer's patients, in order to demonstrate that they have very low brain activity. Another way of examining the brain is by measuring the electric activity of the brain with what is called an electroencephalograph. In this kind of examination, electrodes will be placed on the scalp, on the skin of the head, and will pick up the electrical signals produced as the brain functions. And we know that there are different types of waves based on different types of activities of the brain, including different types of staging of brain activity while we are sleeping. So by doing an electroencephalography, we can do what is called a sleep study. We may diagnose diseases as seizures, localized tumors. We can study the drug effects on the brain, and when we cannot identify any type of waves at the level of the brain, that will determine if a patient is brain dead or not. Because keep in mind, a patient may still be brain dead and have heart and lung activity, especially if that is supported artificially with a ventilator. And here you see examples of those electroencephalography strips, and you can see over here you can see alpha waves that are normally seen in an adult. There are different ways in adults and in children. We have different patterns. You can see the beta waves, how they look when someone is excited or intense concentration. We have theta waves that are typical for a children's brain, and you see how they're scattered in a completely different way. And we have the deep sleep waves or the delta waves when our brain is completely in a state of low activity. On the other side, on the B image, you can see different types of seizures, the first two of them. You can see how hematoma is changing the waves, the normal waves, and you can see how drug poisoning with barbiturates also is changing the aspect of the wave. There is a wide range of disorders of the brain and the associated structures, especially meninges, and we'll dip a little bit in each of those. We'll start with the seizures and epilepsies, and we need to define a seizure. A seizure is the result of abnormal electrical activity of the brain, and as a result of that, what we see on the outside is uncontrollable muscle contractions. They are called tonic-clonic seizures. Whenever there is a loss of awareness on the side of the patient, that's called an absence seizure. What may cause a seizure can be a lot of factors. It can be the result of trauma, infections, electrolyte imbalances, and it's very common to be seen as a result of fever. It's very common in children under age 5 for those fevers that are spiking very quick in matter of minutes to have a febrile seizure. Those are considered benign, and once the brain becomes more mature and the child is passing the age of 5, they do not repeat themselves. There is a very low percentage of children that will develop into having a full seizure condition like epilepsy as a result of those seizures in infancy, as a result of fever, only if they were caused by a spike in fever. A seizure disease is called an epilepsy, and that's a syndrome where the patient exhibits recurrent seizures. Most of the epilepsy conditions are what is called idiopathic. We don't know what caused them. We cannot say that the patient had any kind of trauma or infection or anything that started it in the first place. We diagnose them by performing an EEG study, and we see those waves that I showed you before. You can go back to the previous slide and see two different types of seizures. We treat epilepsy with medication. We have a wide range of medication that we can treat our patient with. Well, epilepsy can be very hard on a lot of patients and can compromise their quality of life, especially if they have a lot of seizure that they are the seizure recur in very short intervals of time. Inflammations, we do have inflammation of both structures, both inflammation of the meninges or inflammations of the brain tissue. If the inflammation affects the meninges, it's called meningitis. Remember, itis is the suffix for inflammation. Meningitis is usually caused by bacteria that may get to the level of the meninges through the ear, through the nose, throat, or carried by the blood if we have a generalized type of infections. In some cases, an injury or an invasive procedure may allow the pathogens to reach the brain. Typical for meningitis is a germ that is called meningococcus. We do perform vaccinations for preventing meningitis with meningococcus, especially in people living in close communities like colleges, dorms. Other types of bacteria that can cause meningitis is the Haemophilus influenzae, E. coli, and Streptococcus pneumonia. Beside bacteria, also viruses can cause meningitis, especially the mumps virus. In terms of clinical aspects of meningitis, what we'll see in this type of patients, they will complain of extreme headache, will have what is called a photophobia, will ask to be allowed to be in a room without any type of light in darkness. They will exhibit what is called a stiff neck, and this can be accompanied by nausea and vomiting. And particular about the vomiting is that normally when someone will vomit, they do have a few signs and symptoms before they know that that will happen. In meningitis, in inflammations of the brain and meninges, the vomiting is explosive. There are no warning signs before that. In order to diagnose meningitis, we perform what is called the lumbar puncture, when we extract a little bit of the cerebrospinal fluid, and we can culture that, and also examine for a high concentration of white blood cells at the level of the CSF that is actually pus in the CSF. We have also encephalitis, which is the inflammation of the brain tissue itself, and for encephalitis, most of the time, the causative agent will be an infection with a virus. Typical for those will be the polio, rabies, HIV in those advanced cases that are defined as AIDS. Those viruses that are insect-borne, carried by a vector like the West Nile virus, and quite rare in extreme infections with measles or chickenpox. Another type of inflammation of the brain tissue can be without the sign of an infection and is the result of exposure to toxic substances or as a reaction to some vaccination. The main clinical aspect of encephalitis is the brain swelling, and in what we see in the patients will be again fever, vomiting, and very quick it can evolve into coma. Hydrocephalus, it's a condition that is characterized by abnormal CSF accumulation within the brain, and it can be the result of an overproduction from the choroid plexus, or in most of the cases will be an impaired drainage of the fluid. And while the production is still the same, the drainage lags behind. So as a result of that, there is a CSF accumulation in the ventricles. And by accumulating, this fluid will put pressure on the brain and it will squeeze it against the skull. The skull, if you remember, in adults, if it happened in adults, the skull is not flexible, is not elastic, it cannot expand. It's a very hard and tough cover. If it happens in babies, when the fontanelles and the sutures between the different skull bones are not yet sealed, that will result in an increase of the size of the skull, sometimes to an enormous size. They look almost like a monster. Along with that will be the pressure that the fluid puts on the brain tissue the will destroy the cells and will end up in loss of brain function. Hydrocephalus is can be the result of congenital malformation, result of tumors, inflammation, or hemorrhages at the level of the brain. Definitely is way more common in infants than in adults, and the treatment for the children is surgical. What we do is we put what is called a shunt or a bypass that will drain the excess of the CSF from the brain inside the peritoneal cavity, inside the abdomen. Cerebrovascular accidents, or CVAs, is the fancy name for the stroke. And the stroke actually represents the third leading cause of death worldwide. And it has two types. One type is what is called an ischemic type of stroke, when a blood clot will obstruct the vessel. And as a result of that, there is ischemia at the level of the brain tissue that was supplied by that blood vessel. The other type is the hemorrhagic type, when a blood vessel will rupture and the blood will spill around the brain tissue, putting pressure on the brain tissue. In addition to that, because the blood vessel ruptures, there will be a lack of perfusion and blood supply to the other areas. It's very common among older people. It increases in frequency over 40 years of age and is related to other comorbidities as diabetes and hypertension, especially that is improper treated or not treated at all. Smoking, alcohol consumption may increase the risk for stroke. What is very important for those patients is for us is to identify as soon as possible the stroke, the condition, and to perform the necessary treatment very, very quick. In terms of what we can do for this type of patients, we can restore the blood flow, and that can be done through surgery, medication, or minimally invasive procedures, catheterization that through the blood vessels can reach the place of the obstruction or the rupture and treat it from inside the blood vessel. And that's the treatment for the acute moment when the stroke happens. However, most of the patients that have a stroke, even those that are receiving the treatment in time, will have long-term side effects. And a lot of them will suffer from what is called a paralysis, a lack of ability to move one side of the body. The long-term treatment will be to regain and retrain those lost functions. Another type, beside the paralysis, which is the inability to move the limbs, we have another type of side effect or a complication of stroke that is called aphasia. Aphasia, meaning without, aphasia meaning means language. It's a loss of or a defect in language communication. Those type of losses may involve the ability to speak or write, which is called expressive aphasia, the way that we express ourselves, or may involve other centers, because there are two different centers in our brain. The centers that are responsible for understanding the written or spoken language, and that type of aphasia is called the receptive aphasia. Humor. At the level, if you remember from the spinal cord, we described over there both benign and malignant tumors is the same at the level of the brain, because we are talking about the same type of tissues and the same structures. Brain tumors may develop in any age. However, it looks like they are way more common in young and middle-aged adults. Most of those tumors, again, will originate not from the nervous system, from the nervous unit functional unit from the neurons, and that's because the neurons, if you remember the neurons do not multiply. Only cells that can multiply can create a tumor. So most tumors will originate from the neuroglia cells. They are called gliomas. Most of the time, those tumors are benign. They do not metastasize. What they do, they grow in size and they put pressure on the structures around. And if you remember, the skull is not elastic, so the brain tissue will be compressed against the tumor. Some other tumors may develop from the meninges, and they are called meningiomas. And depending on their location and the size and the degree of destructiveness, the symptoms will be related to that. If it's a tumor that develops in the occipital area of the brain, there will be more visual symptoms. If it's in the temporal lobe, there will be auditory symptoms. If they are in the frontal lobe, maybe motor, and so forth. Depending which area is involved, we'll see the clinical aspects. In terms of treatments, definitely surgery, followed by radiotherapy, and usually they have good prognosis with that. In terms of malignancies, whenever there is a malignant tumor of the meninges, that will metastasis, will be a metastatic lesion from other cancers in other parts of the body. The most common organs that will metastasize at the level of the brain will be the breast and the prostate. Head injuries, and especially the brain injuries, are a result of head impact or any type of violent head movement, and those can damage the brain. To define a concussion, this is also known as the mild traumatic brain injury. This is a transient, a temporary alteration in brain function and results usually from head trauma. It happens as an acceleration, deceleration events when the head in motion, while like in a car crash that is frontal, the head in motion will suddenly comes to a stop. However, inside, because the brain is still in motion, will hit itself to the inside part of the frontal bones. We have also what is called the post-concussion syndrome, because when this happens, a lot of time there is a loss of consciousness. When the patient comes back, they have amnesia, they do not remember what happened. However, they complain of headaches, dizziness, and vomiting, and a lot of times they are disoriented. The post-concussion syndrome have the same symptoms that can develop and persist for a month and even longer after the injury. In addition to that, they may have mood changes and they may have cognitive deficits. Those patients that had one concussion will be susceptible to future concussions, and every other subsequent concussion can be even more severe and will increase the symptoms. One typical example of this type of lesion is your professional athletes, the football players. And if you are interested in this game, you know that every year those helmets are changed and they are developed to be more resistant and to protect them better. However, those repeated concussions that they suffer will create microtrauma continuously at the level and diffuse trauma in their brain, that as a result of that, they will have loss of cognitive abilities at a very early stage in their life. They may become very aggressive as a result of those changes in the brain, especially to the frontal lobe. Frontal lobe is associated with aggressions when injured. Cerebral palsy is another type of condition that involves a brain injury. And this type of injury occurs before or during the birth process. Is a birth process that was traumatizing to the fetus head. And as a result of that, there is what is called brain ischemia. The brain was not allowed to receive the enough amount of oxygen during the birth process. In terms of clinical aspects, what we see in those babies is that they are paralyzed. It can be all extremities or parts of it. They may have inability to speech or delay in development. And usually it's a very complex type of patient that will need a lot of therapy and a lot of treatments surrounding them. One thing that is encouraging nowadays is the fact that we are using stem cells in treatment of those patients with very high rates of success. And if we stay with the brain injuries, another type of lesion is there will be the hematomas that result from a direct trauma to the head. This type of direct trauma to the head may result in bleeding into or around the meninges. Whenever there is an artery damage, that usually is from a skull fracture. It can be with a skull fracture and even without that. And usually the blow is on the side of the head. We have a main artery on that side, on the temporal side of the head. There will be a bleeding between the dura mater and the skull. And that is called an epidural hematoma, epi on the outside of the dura. Because it's an artery, the bleeding will be rapid and will not going to stop easily, will continue, and that accumulating blood will put pressure on the brain and will put pressure on other blood vessels, stopping the brain from receiving the oxygen. The patient will complain of headache, will come with vomiting and confusion. They may have slurred speech, may show partial paralysis. Very typical for hematomas in head injuries will be dilated pupils or unequal pupils. One is dilated and one is not. One is responsive to light and one is not. They may have a seizure or even they can arrive in a coma. In the case of an epidural hematoma, the pressure needs to be relieved as soon as possible, or the death will result from the pressure on the brain tissue. Another type of vascular injury at the level of the brain is what is called a subdural hematoma. And this is the result of the rupture in the dural sinus, which now will involve the veins. Usually typical blow to the head will be either in the front or the back of the head. And that will create a shearing type of action that will separate the dura from the arachnoid. And that will tear up the tiny vessels, the tiny veins. Now, the subdural hematoma has a completely different aspect. Those will be your patients that will lose consciousness, will come back, will be fine, will be examined, everything is normal. They will go home, will go to sleep, and will die in their sleep because this type of hematoma develops, as opposed to the epidural one, which is very quick and acute. This one is very slow developing and can kill in their sleep. Another type of hematomas are those that will develop inside the brain tissue, and they are called intracerebral hematoma. Then can be the result of penetrating wounds, a skull fracture that will be depressed inside and push fragments of the bone inside the brain tissue can create that. Or again, if we're going back to the stroke, it can be the result of a hemorrhagic stroke. This one is summarizing again your traumatic brain injury, the concussion, where you will see headache, slurred speech, blurred vision. They may be slow to arouse, nausea, and vomiting. What do we do with those type of patients? Well, usually we put the diagnosis of a concussion only after a CT scan, after we did examine the patient and we have an imagistic test that shows that there is no bleeding at the level of the brain. The treatment will be close observation of this person. It can be done depending on the degree of the concussion and the understanding of the family can be done in a facility or at the patient's home. They need to rest and they need a quiet environment with avoidance and any kind of overstimulation, and that will include alcohol, any kind of illicit drugs, and use of electronic devices. The light of the electronic devices is producing an overstimulation of our brain. Another category of conditions of the brain will be your degenerative brain diseases, and probably the one that you heard a lot about is the Alzheimer's disease. And this brain disorder results from an unexplained degeneration of the cerebral cortex and the hippocampus. This condition will develop gradually and will result in a severe intellectual impairment. Along with the intellectual impairment, those patients will have mood changes and a lot of confusion. So the main symptom will be the memory loss, and that will be especially for recent events. And those are the most common early symptoms. Now, there are a lot of dangers associated with an Alzheimer's disease. For those patients, they are prone to injury, they are prone to infection, malnutrition, because they may forget to eat, especially if those patients are living alone. They may aspirate food into their lungs, food or fluids. When we are examining their brain, we see that there are changes. They are very easy to identify on a CT scan. We do have some types of therapy. However, there is no cure for Alzheimer's disease. We have drugs that, if the therapy is started early, the diagnosis is made early, they may improve the mental functions and delay the patient's loss of independence, because that will happen. Now, we are able to tell what neurotransmitter is involved in this condition, and that is acetylcholine. And by preventing the destruction of this one, we can compensate for the loss of neurons. Another condition that is degenerative is called multi-infarct dementia. And this is an accumulation of brain damage in different areas of the brain that results from chronic ischemia, a lack of blood supply that happens repeatedly in a series of very small strokes. It's not a big stroke that will involve a big artery of the brain, but it will be seen on small capillaries in different areas of the brain all the time. Just like in the Alzheimer's disease, the clinical aspect of a patient with multi-infarct dementia is also a progressive loss of memory, an impaired judgment, impairment in the cognitive function. However, it starts at in older patients and is related to hypertension and diabetes. What I would like to mention before I'm moving into the next type of condition is that Alzheimer's disease, they have a component, a genetic component. There is a higher risk for those relatives, first degree relatives of an Alzheimer's patient to develop on their own an Alzheimer's condition at an early age. The Parkinson's disease is also a degenerative condition that is progressive, and what we see in those patients is that they have what is called a rest tremor. Even when they are not moving, they have a certain movement tremor of the hands or the head. They may show up with a rigidity in the limbs and joints, and they have a very specific type of movement that is slow and it involves very, very small steps. This condition is a result of loss of the neurons in the basal nuclei. And those neurons are responsible for secreting a neurotransmitter that is called the dopamine. So this loss will result in an overactivity of the basal nuclei. Usually this type of condition will start in patients around age 50. There is a component of genetic susceptibility. We do have something else that is called Parkinsonism. And it's a syndrome that has similar signs of symptoms. However, it has a different mechanism of production. It's the result of encephalitis or other brain conditions. and in some patients as a result of repeated head injury, like in people involved in contact sports as boxing. The main therapy for the Parkinson disease will be administering medication called L-DOPA that will be that is able to get to the level of the brain and become dopamine over there. And those drugs will mimic the effects of dopamine. Huntington disorder is a hereditary disease, and it involves the corpus striatum of the basal nuclei. And those neurons are those responsible for modulating our motor movements. So our movements are not jerkier and out of control. Once those nuclei are destroyed, the patient will show up exactly this type of movements that are totally out of, they look like they are completely out of control and jerky. This image is showing you the PET neuronal activity in a normal brain and in a brain of an Alzheimer patient. If you remember on PET, I told you that those red areas shows areas that are having high activity. You can see how in a normal brain there's a lot of red, while in an Alzheimer patient it's a lot of blue and purple. That means that those areas of the brain are totally inactive. Nothing happens over there. And what you see here, actually, if you really look into it, the areas that have some activities are occipital areas, which is the eyes. So they do register some visual activity. And those over here are temporal and smelling. So what we can say about this patient is that they see, hear, and smell, but they do not have any other type of cognitive activity in their brain. Question number 6. Which of the following symptoms is suggestive of Alzheimer's disease? Memory loss, tremor, impaired balance, or limb rigidity? Suggestive for Alzheimer's disease is the symptom of memory loss. Tremor is associated with Parkinson, as it is impaired balance and limb rigidity. Cranial nerves. Remember that we had the spinal nerves that were related to the spinal cord. At the level of the brain, we have 12 pairs of cranial nerves, and we have them numbered 1 through 12 in Roman numbers. We have one pair that starts at the cerebrum level, one at the Diencephalon level, and a huge amount of them, you see that they are at the level of the brainstem, which is the more primitive type of brain that we have. In terms of types of impulses that they carry, we have nerves that are special sensory nerves. We have general sensory nerves, somatic, and visceral. Those are the nerves, the 12 nerves, with the area where they start from. And if you look at the legend, you see that the full line represents a sensory nerve, while the dotted line is a motor nerve. And we'll describe every single one of them. So we have number 1, which is the olfactory nerve. By the way, you will need to know them. We really need to know each of them by name and function. Number 1, olfactory nerve, carries impulses related to smell from the nose to the brain. Number 2, the optic nerve, carries impulses from the retina to the brain. Number 3, oculomotor, controls contractions of the muscle eyes. Trochlear, number 4, supplies only one of the muscles of the eye. And when I'm saying the muscles of the eye, we are talking about what is called extrinsic muscles of the eye. Number 5, trigeminal, is called trigeminal because it has 3 branches. Provides sensory information from the eye, upper jaw, and lower jaw. Number 6, abducens, provides motor control for one muscle, extrinsic muscle of the eye. Number 7, or facial nerve, controls the muscles of the facial expression. In addition to that, it's a mixed nerve. it has both motor and sensorial fibers. So it controls the muscles of the facial expression while carrying sensation of taste from the tongue, and it also provides stimulation for the salivary glands and lacrimal glands. Number 8, or vestibulocochlear, that's a pure sensorial nerve, will provide impulses for hearing and balance from the inner ear to the brain. Number 9, the glossopharyngeal nerve carries sensory impulses from the tongue and pharynx or the throat, along with controlling the swallowing. So it's also a mixed type of nerve, having both motor and sensorial fibers in it. Number 10, or the vagus nerve. This is the longest nerve that we have in our body. It starts at the level of the brain and continues down through the neck, thoracic cavity, inside the abdomen, and provides supplies motor functions to most of the organs in the thoracic and abdominal cavity, including impulses to the larynx and pharynx. Number 11, the accessory nerve, controls the muscles of the neck and the larynx. And the number 12, the hypoglossal, controls the muscles of the tongue. So in terms of disorders of the nerves, it is kind of easy to understand that when there is a visual impairment, that will be a disease that involves nerve number 2. Hearing impairments can be a result of a lesion of cranial nerve number 8. There is a condition where we have a drooping eyelid that can be unilateral on only one side, and that's a condition that will involve the cranial nerve number 3. There is a condition that involves facial nerve, or nerve number 7, that is a partial facial paralysis that is called Bell palsy, and that will be seen on only half of the face, and it's usually following an infection, a viral infection, and it's considered to be an autoimmune condition. We have also a condition that is called a neuralgia, trigeminal neuralgia, that affects the nerve number 5, and it manifests itself as a very painful condition of the face. The patient will report having painful twitches of the face on that side. Is usually unilateral. Question number 7, which cranial nerve is concerned with the sense of smell? And the options are vagus nerve, trigeminal nerve, olfactory nerve, and hypoglossal nerve. The nerve responsible for the sense of smell is the olfactory nerve. Vagus nerve provides innervation for the thoracic and abdominal organs. Trigeminal nerve will provide sensorial information from the level of the face through 3 branches, while hypoglossal nerve commands the motility of the tongue. Effects of aging on the nervous system. Nervous system is the first system that shows up in an embryo and can be highly affected in those first 5 weeks of intrauterine life. Once the nervous system reaches its maturation stage, that moment the degenerative changes will start to show up. The neurons and the glial cells that die will not going to be replaced. There will be a decreasing in size and weight of the brain while we become older. And the decrease in size and weight is also related to the fact that our body becomes more and more dehydrated, relatively dehydrated while we become older. There will be a neural loss at the cerebral cortex. There can be a decrease at the level of the neurotransmitter productions. Along with aging, we develop fewer synapses, and as a result of fewer synapses, the information will be processed and transferred at a slower rate. The memory is decreasing, especially for those recent events, while long-term memory still is intact. You'll see that many of your patients will remember what they did in their 20s, but they cannot remember if they had anything to eat that morning. As a result of changes at the level of the cardiovascular system, and especially in the arteries through the atherosclerosis process, there will be a narrowing of the arteries with a reduced blood flow to the brain, and as a result of that will be what is called the vascular degeneration that can become even a stroke in some cases. As a general rule, while we grow older, our ability to acquire new skills and learn new tasks decreases.